Thank you, Tuminder, and the President of and the Council of the OCCP for inviting us, the College of Cardiology, to take part in this important symposium. My topic, of course, update of the stimulation myocardial infarction, is a very applicable topic for the day, and I have no interest, financial interest or conflict. The important thing is we know that it is the #1 killer worldwide. And out of 3/4 of cardiac deaths occur in low and middle income countries like Sri Lanka. And we see now, day by day, incidence of coronary disease rapidly increasing among young population. We see a lot of young people coming with acute myocardial infarction without obvious risk factors. I'm sure you have seen this many times, but I would like to start because this is the basic pathophysiology of acute coronary syndromes. The plaque develop over the years, start developing maybe or start with 10-15 years. This due to our negligence or not appropriate action taken, they develop lipid plaques in the subendothelial area, and the day it causes plaque erosion or plaque rupture, the blood exposed to the underneath tissue causing platelet aggregation. It causes platelet thrombi causing white thrombi, and then gradually progress to the red, the fibrinogen join and cause large thrombus, red thrombus. And it presents with like unstable angina or non-STEMI when the plaque, the material, the platelet thrombi get embolized, cause microinfarcts causing troponin I causing non-ST elevation, or the vessel totally occluded causing ST elevation MI. So these three categories, ST elevation MI, non-ST elevation are very common, but both conditions, the morbidity and mortality almost the same. The clinical diagnosis of paramount importance in making a proper management. Because most of the we see without taking proper history, patients are being treated for acute coronary syndrome. Sometimes you miss ST elevation MI by not taking proper history. The typical presentation is the angina. Typical angina is tightening, compressing, burning, or heavy thing. In the center of chest, it extends from epigastrium to the lower jaw, like epigastrium, retrocularia, throat, lower jaw, and teeth, and could radiate to both arms and go back to the back of chest and associated with autonomic symptoms. So this is very typical. So when you get these symptoms, you must suspect acute coronary event. Diagnosis, I think you should know. The important thing I would highlight, inferior myocardial infarction, always we should take V3, V4, because that is the one causing high morbidity, high mortality. If you miss a right RV, in fact, the inferior, the two problems is complete heart block, it can be reversed easily, but when you get a right RV, in fact, that can cause a lot of disaster like hypotension episode, cardiac shock. So that has to be diagnosed early and take prompt action. And this is the ECG of true posterior MI. You can see the ST reciprocal ST depressions in V1 to V3. These patients almost always should do posteriorly V7, V8, and V9. That will show ST elevation. So it's very important that you should do V7, V8 to make a proper diagnosis. And this is left bundle block, all of you know, but the patient presenting with typical symptoms of left bundle branch block, probably he may have been all ECG normal, but sometimes you may not have the all ECGs. You always suspect acute coronary event. And this is right bundle branch block with ST elevation. And if you have ST elevation, typical symptoms, because this one, of course, shows ST elevation, then you can make ST elevation diagnosis. But that indicates that extensive damage to cause right bundle branch, the damage has to be extensive. So it indicates extensive myocardial infarction. And this is a chest pain with pacemaker. Anybody having with pacemaker, it's a little confusing, but you can see ST depression, ST elevation. But history is the most important thing. And this is a very common presentation. I think almost all of you, I think, know this. Diffuse ST elevation with ST elevation, diffuse ST depression with ST elevation AVR, that signifies critical left main disease or critical three vessel disease, or left ventricular. So these patients should go to cath lab as early as possible. If you delay, there could be high morbidity, high mortality. And there are occasionally the atypical presentation, then you get hyperactive T inversions. When you highly suspect and you do repeat ECG to confirm it, or sometimes occluded circumflex acute occlusion of vein grafts, left main disease may present without ST elevation. So as I would reiterate the importance of making a proper diagnosis. So ECG alone won't help you. But this scenario, if you have an echocardiogram, then you can look at the wall motion abnormality. That will confirm that even the STs are not there. You do echocardiogram, the history suggests you do echo, you can see the wall abnormalities, anterior wall apex, and septal unit as extensive anterior MI. Usually we are guided by these two colleges, SEC and ESC. We follow, of course, we don't have our own guidelines, so we follow these things. Mostly the ESC. And the management of the goal is, time is muscle. More you delay, more damage. So we have to achieve prompt, complete, and sustained reperfusion, that is STEMI 3 flow of the infarct-related artery. So there's you have to act as early as possible. As you can see from this slide, very clearly this, as you delay, the mortality reduction becomes less and less, and as you go after 3 hours, 4 hours, it becomes less. So that is why you have to act very early. And how can you improve? This diagram present of the delays which can occur and how can we control this. There's a patient delay. In spite of repeated lectures, TV programs by doctors and other people, still patients don't come on time. That is very sad, including doctors. Doctors are people who come in last. And the ECG system delay, when you come to the hospital, you have to take an ECG within 10 minutes and make a diagnosis. But I don't know how much delay happening in the hospitals. We know when you come to ECG, check ECG technician go into ward rounds and but this is very, very critical, bad situation. And also once you make a diagnosis, you have to act promptly. As I said, muscle is time is muscle, therefore act quickly. You have decided either you do, the medical management won't help, either start thrombolysis or PCI. These are two options for us. And this is the management protocol. If a patient comes first to a PCI center like National Hospital Colombo, you make a diagnosis within 10 minutes by doing ECG, you can see ST elevations. Then you immediately transfer the patient to the PCI lab, not to the CCU, not to any other place, directly coordinate with this, minimize delays, and send to the patient for reperfusion. That is, we don't talk about need to balloon time anymore. We talk about door to wire crossing time. Sorry. And the patient comes to non-PCI centers, instance goes to Ragama Samya. What to do? Again, you make a diagnosis within 10 minutes, and depending on the time delay, you have to decide. If you think you can get the patient through to the cath lab and get the vessel open within 120 minutes, you transfer the patient to for PCI. If there's a delay, you have to do immediate thrombolysis within 10 minutes. Within 10 minutes. I would like to highlight this guideline with cases. This is a patient of 55 years old patient presented to Basel Panadura with chest pain for 2 hours duration. ECG shows anterior stimulation MI, no contraindication or thrombolysis, expected delay with the highway maybe 45 minutes assume. What is initial management? Most simple, as they come in, you go aspirin and dual antiplatelets. You give aspirin, of course we don't have IV aspirin. And then mostly the acute myocardial infarction, acute chronic ischemia, what you should give is either prasugrel or ticagrelor. I don't know how many hospitals you have this. It's not in the government health hospital as far as I know. But if you have it, that is the best to give because these are standard type class 1A indications for acute coronary syndrome. If neither is available, you give topical 300 to 600 milligram loading dose. And Cangrel, of course, not available. That is a very good drug, gives quick action, onset and offset action. Then action wanes off within few minutes. And then, you give all the patient, when the patient comes chest pain, you see everybody with a face mask. Is that right? Absolutely no. If the saturation is less than 90, they need oxygen. If the saturation is more than 90, they don't need oxygen. Actually, it's 3B that is harmful. It's not actually not only good, it is harmful. Therefore, you should never give oxygen to a patient with saturation more than 90. And also, commonly they are having chest pain, so we have to give pain relief like major analgesia like opioids. The disadvantage is if you give opioids like morphine, it slow uptake, delayed onset of action, and diminished effect of antiplatelet. So that may be adversely affect the action of this the antiplatelet effect. And also, if your patient is only anxious, you can manage with tranquilizer like benzodiazepine, like diazepam, to keep the patient calm. So once you give the basic treatment, antiplatelets, oxygen and all that, reassurance, painkiller, then you have to decide what is the basic management. If the patient comes to the, like Colombo, if primary PCI, immediately you consider send to the cath lab for primary PCI. I know it is not possible, practicable, all that, but that is what you should target for. The patient of non-PCI center, if the delay is going to be more than 120 minutes, patient should be given thrombolysis immediately within 10 minutes. But if the patient delays less than 120, patient should be transferred to primary PCI center for opening up the artery. That's what. So if the patient is here, assume our patient from part of the review, assume that patient could be sent to cath lab and open that within 120 minutes. You immediately transfer the patient, inform the cath lab in advance, keep the cath lab ready, and do primary. That is the best way of managing these patients. And if you look at the guideline, reperfusion therapy is indicated in all patients with symptoms of ischemia less than 12 hours duration with persistent ST elevation. So all these patients should be given reperfusion, either thrombolysis or PCI. The primary PCI strategies are recommended for over thrombolysis within indicated hours. I mean, if the patient comes early, thrombolysis, PCI is the best, not the thrombolysis. But first 3 hours, of course, thrombolysis is also very effective. If timely PCI cannot be performed after ST elevation, MI, fibrillary therapy is recommended within 12 hours. So it's going up to 12 hours. You know, as you go on, you get more and more thrombi formation, then thrombolytics won't be effective. So all three are 1A evidence. And, And then, as I said earlier, procedural and ticagrelor, or if clopidogrel not available, clopidogrel is the drug of choice given for these patients. And after all that, you give in the cath lab unfractured heparin. If you have heparin-induced thrombocytopenia, you have to use biology, which is not available to us at the moment. We had it few months ago, few years ago. Pontoconazole is contraindicated because it can cause the catheter thrombosis. And routine post-procedure, post-angioplasty anticoagulant therapy is not indicated. Then I move to the next case. There's a 65-year-old patient admitted Ratnapura with chest pain for 2 hours, diabetic hypertension, risk factor smoker, ST elevation myocardial infarction. The expected delay is minimum 3 hours. What are we going to do? Obviously, we have no cath lab in the near vicinity of Ratnapura, so we have to do Colombo. It took more than 3 hours, so we should decide what to do. We see what you do. You can give full dose fibrillary therapy and urgent transfer PCI, whether to transfer immediately for primary PCI, that is out, as I said, and start glycoprotein 2B3, and no, that is not indicated. So what you should do with these patients, as guideline indicates, if not, if PCI not possible, you do immediate thrombolysis. As I said earlier, the time is muscle. So we have to give thrombolysis in this particular patient. What are the available thrombolytics? Fortunately, we have TNK now. Earlier, mostly to a streptokinase. If you give streptokinase, TIMI3 flow, I don't know whether you know TIMI3 flow means when you have occlusion, if they're totally occlusive, we call TIMI0 flow. If a trickle of blood going down the vessel, we call TIMI1 flow. If it takes about 4 or 5 cycles to fill, we call TIMI2 flow. If the brisk flow, we call TIMI3 flow. So what we expect to target to have TIMI3 flow, but streptokinase provide only about 32%, but TIMI2 to 3 about 50%. TME2 also, okay, reasonable. But with TNK, you get about 60% TME3 flow and 2 to 3 about 80%. So that is quite good response. So fortunately, we have TNK at the moment. At most hospitals, they use TNK now. These patients, what should we give antiplatelets? Aspirin, obviously, you have to give. We cannot give ticagrelor or prasugrel because those are potent when they have high risk of bleeding. These patients should be given only clopidogrel. But after 40 hours, when the thrombolytic effect is gone, you can go back to the potent antiplatelet like prasugrel and ticagrelor. And enoxaparin, again, all these patients, if you go TNK, all the patients should be on given enoxaparin, 30 milligrams IV stat followed by 1 milligram per kg, maybe up to the hospital stay, or as soon as you do the PCI, you can stop giving enoxaparin. The elderly patient, you know bolus, enoxaparin only give 0.75 milligram per kg dose till such time the patient needs it. Heparin or pontoparnex also can be given in the patient who are managing with thrombolysis, not with PCI patients. And now this patient, you give aspirin 300, clopidogrel 300, atorvastatin, interventional enoxaparin. What is your next step? Now we should decide, we have given thrombolysis, how effective it is. We should know assess whether the medical thrombolysis is successful or not. How do you assess it? If unsuccessful, the ST secondary dissolution less than 50% within 60 to 90 minutes after. So you can't just give thrombolysis, go home and sleep. You have to assess the patient within 6 to 9 whether it has come down, at least 50%. Or presence of, if the patient has hemodynamic and electric instability, you have to transfer the patient, or worsening ischemia or persistent ischemia. All these patients we need that we know it is not successful, we have to do something more than thrombolysis. So these patients you transfer to PCI capable centers for rescue PCI. Once you give thrombolysis, if fails, you send for rescue PCI if the following are present, like failed thrombolysis. Sometimes you can get reocclusion of these arteries, life-threatening arrhythmias or cardiac arrest. This is not uncommon. And also with extensive anterior MI, there could be acute heart failure, hemodynamic instability, or mechanical complications like valve rupture, mitral regurgitation, septal perforations, or free wall perforation. They should be immediately sent to a PCI center or a major center for surgical intervention. Now this patient, now we are told we have given thrombolysis, immunothrombolysis within 10 minutes. Then what to do? Then if the failed thrombolysis, as I said, it should be sent to rescue PCI, to the center, to a PCI center. Case number 3, I think you understand. If you have any questions, you can ask, I think, after the lecture. There's a 42 years female presented with 2 hours of onset chest pain, anterolateral MI, success thrombolysis TNK ST said come down, patient symptom free. Is on aspirin, clopidogrel, statin, beta blocker, and enoxaparin. What is the next step? Now we have given thrombolysis, patient come early, patient far away place, we can't give PCI, so we give thrombolysis. Now what are we going to do? This is our guideline. Early angiography within 24 hours is recommended if symptoms are completely relieved and ST segment elevation is completely normalized, spontaneous or after ETN. So even if it is calm within 24 hours, patient should need angiography. I know this is not practicable in our setup, but this is our goal. One day we have to achieve this goal. So this is a diagram representation. I will show you our immunothrombolysis. It fails. I told you we'll do a rescue PCI. The balance of patient, you give thrombolysis, successful reperfusion, patient symptom free, still you should try and do angiography early within 2 to 24 hours. So successful thrombolysis doesn't live there because we need to give the thrombolysis. It dissolves the clot, but the disturbed plaque will be there. If you don't fix the plaque, it might thrombose again or restenosis again. So all these ideally should be angio and do PCI. I got a 4th case anytime. For 60 years male presented with TH to Raghav Hospital with the chest pain, 16 hours. Now patient has been having chest pain for 16 hours. ECG shows infralateral MI, human is stable, no indication of Thrombolysis. What is the next step in the management? In patients, this ESA latest guideline is in patients with time from symptom more than 12 hours. Primary PCI strategy is indicated in the presence of ongoing symptoms with hemodynamic instability or life-threatening anemia. So all these patients should be having angio and angioplasty. Because thrombolysis, I said after 12 hours, there's no point giving thrombolysis because already the large thrombus burden, it cannot be dissolved with thrombolysis, so you have to do primary PCI. The patient coming late, ongoing chest pain, you have to do all these patients. The number 5, this is a 60 years old female patient with chronic AF and on warfarin developing anterolateral MI. You know, this patient, the risk of bleeding is quite high, so inevitably they are not suitable for thrombolysis. So oral anticoagulation is a relative contraindication for fibrinolysis, and they should try to primary PCI strategy regardless of the time delay. And patients should receive additional parenteral anticoagulation regardless of whether they are on anticoagulation. So whether they are on anticoagulation, you have to give heparin during the procedure, otherwise they can get thrombus. And glycoprotein 2B3 avoided because of high bleeding risk. So this patient loading aspirin as usually you give 300 dose. And you can't give, again, you can't give prasugrel or ticagrelor because high bleeding risk, you give only clopidogrel. The drug of choice, you can give 600 ml loading dose before PCI. And ideally, chronic anticoagulant regime should not be stopped during the admission. You should continue. So these patients after primary PCI, the post-procedure triple therapy for maximum 6 hours, we of course try to minimize it because of the high bleeding risk. Particularly elderly people or renal failure patients, like we try to reduce the dose. And after 6 months, of course, you make dual therapy like antiplatelet and anticoagulation. After 1 year, you continue only anticoagulation therapy. Actually, our management doesn't end there. You go thrombo PCI and send the patient home. No, we have to take care of the patient post-op. This patient has to be in ICU for 24 hours minimum, and stable patient with minimum day, you do echocardiogram. If the patient LV function normal, there are no arrhythmia, we know that patient, stable patient can be sent home within after 48 to 72 hours. Nowadays, they recommend even, you cannot in guideline, but they recommend even after 24 hours, the patient is stable, no damage to, no arrhythmia, you can send after 1 day, provided that somebody there at home to take care of the patient and live in the close vicinity. And also, you have to make sure that behavioral modification like stop smoking, all the other advice, exercise, all this to be addressed. Most important thing is nutrition. You have to advise about nutrition, that that's part of management of myocardial infarction. And of course, you can go diet protocol with the dietitian. And then cardiac rehabilitation. Unfortunately, this is not much practice in the private sector, but for good thanks to our cardiologists, we practice most of the government hospitals, and it gives reduce all-cause mortality by 11 to 26%, cardiac mortality by 26 to 36%, and unplanned hospital admission by 28 to 6%. You can understand how beneficial by cardiac rehabilitation for this patient. If you look at the guideline, particularly in the cardiac rehabilitation program for patients hospitalized for acute coronary event or revascularization is class 1A indication. So all these patients should undergo cardiac rehabilitation. They take home messages. Early diagnosis and prompt initiation revascularization therapy is the key to success in management of ventilation MI. Reperfusion delays could be minimized by educating patient population and improving care in emergency department. And develop infrastructure, maximum usage of available cath lab facilities for patients with acute coronary events would significantly reduce the cardiac morbidity and mortality. And educating children from early days to healthy lifestyle would the only long-lasting solution for this ever-increasing but preventable disease. Thank you.